My name is David Seljak, and I'm the director of the St. Jerome's Center for Catholic Experience. Welcome to St. Jerome's, and welcome to tonight's lecture. As you can see, the John Sweeney Lecture in Current Issues in Healthcare, featuring Dr. Smith, Dr. Kevin Smith of St. Joseph Healthcare System and St. Mary's General Hospital. Given that this is a time of Lent, a time of repentance, I thought I'd tell a joke. An Irishman walks into a bar in New York and orders 3 beers. And he does this on every occasion in which he walks into the bar. And he orders 3 Guinness every time. And finally, the bartender's curiosity gets the best of him, and he asks them why. And he says, well, when I left Ireland, my 3 brothers, we always drank together. We were 3 brothers, we always drank together. And so when I left for Canada and the other one left for the United States, we always promised that we'd order our beers in 3 so that we'd remember the other 2. And so he'd order his 3 beers. This went on for some time. And finally, the man walks into the bar and he orders 2 Guinness. And this goes on for a few days, a few weeks, and the bartender's concerned. He says, I don't want to pry into family business, but is something wrong with one of your brothers? He goes, oh, no, my brothers are just fine. I myself have given up beer for Lent. Well, I've given up coffee for Lent, so if this is a little less coherent than it should be, then you'll know why. I mean, I know these Lenten practices are to get us to identify with the passion of our Lord on the cross. And now I know how Jesus felt when he was dying of thirst and he got a sponge full of vinegar instead of a extra large double-double from Timmy's that he had ordered. Tonight we have both a lecture and a celebration. The John Sweeney Lecture in Current Issues in Healthcare is a celebration of the life of John Sweeney and the contribution he made to St. Mary's General Hospital, the St. Joseph's Healthcare System, and St. Jerome's University. It is also a celebration of the common Catholic heritage that those 3 public institutions have in common and the project of a more fully human society that they pursue. And finally, it is a celebration of that meeting place between Catholic values and Canadian values. I would like to welcome members of the St. Mary's General Hospital community, especially Moira Taylor, president of the hospital, Doug Letson, a stranger to these halls to be sure, who is now chair of the board of St. Mary's General Hospital and, of course, president emeritus of St. Jerome's, Andre Anderson, the chair of the board of the St. Mary's General Hospital Foundation, and generous donors to the St. Mary's General Hospital Foundation who have joined us this evening. I would also like to welcome especially Peter Sweeney, the executive director of the St. Mary's General Hospital Foundation, with whom I work most closely organizing this lecture. And I thought about all the people that I thank and introduce during one of these events, and I thought, I've never thanked Peter for those years of collaboration, and it's been a very fruitful and warm collaboration between us. The series this year, the St. Jerome Center series this year is called Amazing Church. And one thing that is amazing about our church is that we build hospitals. And we run them, and we do it a lot. There are more than 87 Catholic hospitals in Canada, some several hundreds in the United States, some several thousands around the world. It is not necessary that a religious community run hospitals, but Christians have done so. And perhaps it would have been easier on us if Jesus did not heal the sick, if he did not give us the parable of the Good Samaritan, if he did not tell us to visit the sick and to care for them. But it is part and parcel of the Christian message, part and part of our project together. And so it is in that spirit that we are proud to present tonight's John Sweeney Lecture, Public or Private, the Impact of the Supreme Court Decision on Healthcare Delivery, by Dr. Kevin Smith. To introduce Dr. Kevin Smith, I now call upon Tom Motes, a generous volunteer both at St. Mary's General Hospital and at the Foundation, to introduce our speaker. Mr. Motes.
We're playing past the microphone. It's my great pleasure to add my words of welcome to this, the 4th annual John Sweeney Lecture on behalf of all of us associated with St. Mary's General Hospital and its foundation. This is an important event in the life of St. Mary's when we honor an individual whose commitment to public life in general and to our hospital specifically reminds us all of the effect that one person can have in the community. The annual John Sweeney Lecture and Current Issues in Catholic Healthcare was initiated by St. Mary's General Hospital in honor of John Sweeney, who died in July of 2001. Among his many contributions to the community, John served on the board of trustees of St. Mary's for 10 years, and the hospital benefited immensely from his wisdom and commitment. And John was also committed to the notion that faith and public service need not be incompatible. The St. Mary's General Hospital Foundation and the Sisters of St. Joseph of Hamilton jointly fund this lecture. We're grateful for the opportunity to remember and to honor an individual who touched our organization so profoundly. If you'd like to help us carry on this lecture, you'll find donor cards in the seats supporting the Sweeney Endowment. And if you'd like, you can take one and leave a donation at the table at the back. I'd also like to recognize Kay Sweeney and members of her family who are with us here tonight on this special occasion. With healthcare continuing to dominate the public agenda, it's especially fitting tonight that we welcome Dr. Kevin Smith to provide his perspective on the effect of the recent Supreme Court decision on our notions of public and private healthcare delivery. Kevin is CEO of St. Mary's General Hospital here in Kitchener-Waterloo and President and CEO of St. Joseph's Healthcare in Hamilton, sorry about that. He's a very engaging speaker, I know that, having talked to him a number of times, with an insightful perspective on the nuances that make up our often complex healthcare system. I'm sure you'll find the lecture both informative and thought-provoking, so please give a warm welcome to Dr. Kevin Smith.
I think that's good. Can you hear me all? Excellent. Well, thank you very, very much. It's a real pleasure for me to be here this evening. It's an honor, in fact, especially following the very impressive speakers of before, and I fear I might bring down the tenor of the talk thinking about the previous lecturers, so I'm going to do my best and beg your indulgence. I do want to confess that I've never had the pleasure to meet John Sweeney, but I've heard a great deal about him, both during my time at St. Mary's and prior to that, obviously through the political process. So Mrs. Sweeney family, what a great opportunity for us to celebrate a remarkable man. And I understand that Mr. Sweeney was also the first Chancellor of St. Jerome's, and again, another very important reason why we're here having this discussion tonight. Well, there they are, the Rogues Gallery of Healthcare in Canada, and I think Ralph is actually the most impressive on the list, especially now that he's going. But in addition to the rogues, there's some heroes, and I think that some of us might be here tonight. I don't know if Elizabeth Whitmer was able to stay, but I did see her earlier at the reception. And there she is, a great hero of healthcare, in my opinion. And also Regional Chair Ken Sealing. I think that might be a little bit of a political meeting back there. Some money might be negotiated. I think that's a good thing for Kitchener-Waterloo. Ken, a pleasure to see you again. And I also believe I just had the opportunity to meet Jan Daly, who is one of our council persons. So again, a pleasure to welcome you and to meet you a little earlier this evening. Well, let me tell you a little story. Hopefully it won't be too long, but my friend Brian Guest is back there, and he promised he'd start going like this if I rambled on for too long. The first slide, if I could. The story goes a little like this. Jacques Chiouli, George Zeliotis versus the Attorney General of Quebec and the Attorney General of Canada. And you'll remember this story is a story of wait time advocates. Chiouli is a physician who attempted to get a license so that he might offer services at a private hospital. Together, Zeliotis, Chiouli, and of course the government of Quebec have in fact challenged the prohibition on private health care. I'd remind you that the decision was a decision of the Supreme Court of Canada, but it was a decision made about Quebec law. It was argued June the 8th and decided June the 9th. Shauli and Zeliotis, as I mentioned, versus the Attorney General of Quebec and Canada. The ruling was that the Quebec Health Insurance Act and the Hospital Insurance Act prohibiting private medical insurance did in fact violate the Charter of Rights and Freedoms. It was, however, a 4-3 decision. The court found that the act did in fact violate Quebecers' rights to safety and security, and those are important words. I'd, however, add it was somewhat controversial. It was a 4-3 decision. Now, just to never forget Tommy Douglas, a little memory of him here at St. Jerome's, it seems especially fitting. Medicare, some of our cartoonists suggested that could it be the end of Medicare? Others suggest that the death of one-tier health care meant a much worse outcome. And I don't think we should immediately jump to that, but I believe that there might be some opportunities to find the best in combining both private and public. Next slide, please. Deschamps, who was one of the justices, argued that the government responsibility to protect citizens and the existing wide range of control over health resources was incredibly important. McLaughlin and Major, similarly, two other justices, that government health system must conform with the Charter of Rights and Freedoms and the Quebec provisions to harm right from security of person. Now, I won't bore you with the details of the names of all the justices involved, but as I mentioned, it was a split decision with, again, 3 in favor. 2 wrote against the decision, and they are on the following slide. Benny and Lebel, in their opinion, in these 2 justices' opinion, the issue is one of whether the Quebec government has the right to favor the public health system. They described the problem as an issue of public policy and social values. The court, in their opinion, cannot determine what a reasonable wait time is. That is, in fact, a clinical decision, and we should honor it as such in their view. And they continue to disagree that Quebec law is arbitrary. The claim is based on generalizations about the public system. All provinces have legislation to safeguard the public system. And the overwhelming theme, healthcare should be based on need, not wealth. Again, the 2 polar debates of public and private healthcare. Well, what are the immediate implications? Well, the most profound implication was a lot of column inches, a lot of media airtime, a lot of talks being given about what does this mean and where are we going. I believe that the renewed interests of governments were no doubt piqued by this, and the concept of allowing private insurers and private care for those with the resources to relieve pressure on the public system was certainly a theme that was advanced. The direct implications for the provinces with a legislative safeguard to the public system also was something that was widely discussed, and I'm sure you've seen it in the media as I have. Well, to go back to a former Sweeney lecturer, let me remind you what Mr. Romano said in the Globe and Mail. And as you can see, his concept was one where his Royal Commission on Health Care went in a different direction. He believes the ruling undermines the Canada Health Act by not allowing private insurance on terms and conditions that are not uniform. Mr. Romano also noted that the ruling was based on the notion of reasonable wait time, again, a topic that should, will, and continue to be under wide discussion. Similarly, they recognized, as Mr. Romano pushed forward, that there were sites in the United States where more than 50% of last year's bankruptcies were due to healthcare costs. And obviously, that had implications in cutting jobs. It was stated at General Motors that the single biggest cost per car to produce was no longer steel. It was, in fact, per car, the cost of healthcare for a General Motors employee. Of course, the other issue comes back to a long-held debate, long-held view around primary care and home care reforms, around health promotion, and again back to that theme that we will and are seeing from all governments, the whole theme of wait times. Well, the Quebec government in November 2005 had leaked, or unfortunately had leaked, I guess depending upon where you sit, a draft leaked to the media. And the response of the Quebec government, the Charest government, was with respect to limited private reforms. the government proposed a purchase of private medical insurance and a minimum quota of public system work to keep doctors from leaving the public system. So in other words, not unlike pre-Medicare, it would be expected that a significant portion of time, not unlike in the National Health Service of Great Britain, would be dedicated to the public sector. Remaining time after a number of years in service could in fact be delivered to a quote-unquote private sector. Between November 2005 and January 2006, some of the following issues occurred. Between November and December, we saw some provinces announce that they will not meet the deadline to set, again, medically acceptable wait times, a topic that will continue to be of hot debate. In December and January of 2006, the federal election platform emerged, and wait time guarantees, care guarantees, were very much part of the discussion across political parties. In January, Alberta, the hip and knee replacement project came forward with some rather shocking news, good news in my opinion, that saw a coordination of care, a consolidation of care, and within the best sense of the word, the quote-unquote medical factory model that allowed us to bring very, very low acuity, high volume issues to bear, and to again look at a process for both screening, treatment, and triage, which significantly reduced waiting times. By February of 2006, the British Columbia speech from the throne announces public sector consultation the greater role of the private sector. I'll remind you that this is a Liberal government currently in British Columbia. By February, the Quebec government again responded to Shirley with care guarantees and pledges to pay for private surgeries if guarantees were not met by the public system. This model allows private insurance, but not public and private physicians as yet. A few more reactions to the rulings. Obviously, the fear of a two-tiered system, or that Medicare will be weakened. Do we wish to philosophically, ethically, socially live in a country where your wealth could define whether or not your access was appropriate? Again, a very, very important question, a question very near to Canadian hearts. Some had optimism that the private care system can relieve pressure on the public system. Again, the thought is, how does one do that while still guaranteeing issues of access, issues of equity, and issues of high-quality service? Some also remain concerned about the high economic burden. If one looks south of the border, the cost of health care per person is remarkably higher than ours, and I'll show you a little bit of data on that in a moment or two. But might this evolution of private involvement simply drive the dollars up, again bring more cost to the system, and in fact produce no more health per se or no more well-being? Certainly we've heard to a large degree confusion around the unionized labor movement and the issues of lower wages. Much to the surprise of many, none of the agreements so far have talked about how one would, quote-unquote, contract out work. In my opinion, those are two completely separate initiatives to talk about how one remunerates costs and lives up to bargaining agreements, as opposed to talking about a delivery model that may allow the public system to work in concert with the private system while remaining true to the Canada Health Act and actually deliver more care with at least as good quality and similar outcomes, if not better outcomes. And of course, a cultural shift, that physicians would no longer be bound to the only system, but that the door might be opened so wide that we would in fact see our best practitioners migrate once again to only those who could pay. Well, in addition to all this backdrop, the work of the Supreme Court and others, we had some other things occur across the country, right here in Ontario. In February 2006, a decision that OHIP must reimburse a patient, in this case patient Roots, for diagnostic treatment sought in the United States. And you may remember this. This was quite widely heralded in the media. Mr. Roots was at the Cleveland Clinic, received care, claimed that his care should have been provided in Canada, and after review was in fact awarded such. The decision was based on potential delays in Ontario for cancer surgery. So again, the theme of wait times, the theme of reasonableness in meeting clinical demand. The outcome, to many, Ontario patients are entitled to and will be reimbursed for access to the U.S. system if access is limited in Canada. And I think for policymakers, for elected officials, and for healthcare providers, perhaps to a smaller degree, this was, in fact, an opening that was heralded quite positively simply because of the challenge of access and the worry about wait times. And you've heard this debate, I'm sure, already. Hopefully many of you have participated in it. And that is, does advantaging some illnesses on a wait time strategy, in fact, simply disadvantage others? Is there, in fact, adequate capacity in the Ontario system to respond to the overall needs of our citizens? Well, let me before I come to that, answer that, or try to answer that very imposing question, give you a little bit more information. There's been a flood of legal activity. I know you'll all be happy to know that lawyers, regardless of whether it'll be public or private, will have an opportunity to bill. If there are any lawyers in the room, the healthcare system congratulates you, and we're grateful for it. But they believe the move is on, and further shifts, according to jurisprudence, suggest that the war over the future of healthcare funding away from the political realm and into the courts may in fact be the salvation, that we will in fact depoliticize this discussion and actually come at this from a model of evidence in the judiciary term, as well as a model of evidence in the clinical term to look at what appropriate wait times might look like and what shall we do if inappropriate wait times ensue. Mr. Liswood, a legal counsel in a large firm in Toronto, a 500-lawyer firm, talks about this as being on the edge of a real explosion. As a lawyer, he's wise enough to never say if that's a positive explosion or a negative explosion. And to some degree, I think that depends on how you, Canadians, Ontarians, choose to perceive that. In addition, a Toronto resident will this June appear in Ontario's Divisional Court asking for reimbursement of more than $400,000 for a life-saving operation that he had obtained in England after he was turned down in Ontario. And he and his counsel are citing case law as the Roots decision would suggest. So again, we are pushing that boundary. We are now pushing the courts to respond to issues that historically we've asked the political process to address. I hope you enjoy this slide. I understand I might go to jail for reproducing a $10 bill, but I only heard that this afternoon. So I'll do my best. Wait time strategies do, however, exist today, and performance expectations for hospitals in all provinces exist. Then Minister Whitmer played a very important role working with the Ontario Hospital Association, working with a group called the Joint Policy and Planning Committee, to really begin looking at how funding allocations occur. And of course, Minister Smitherman continues that work, particularly as we look at highly acute areas and areas that have very, very significant risk if not addressed in a reasonable period of time. Medically acceptable wait times that have been deemed as clinically appropriate as well as economically affordable, include areas such as cardiac care, a service near and dear to St. Mary's Heart, thanks to the expansion on that program. Cancer treatment, a service near and dear to Grand River Hospital's heart, again on behalf of the citizens of our region. Issues of diagnostic imaging, primarily MRI and CT scanning, joint replacements, and cataract surgeries primarily. Benchmarks, as in many other metrics of business, are making their way loudly and clearly into hospitals, into healthcare. And again, we are being challenged, in my opinion, legitimately, to answer the question, if others can do it with less expense, similar outcome, similar satisfaction, and equal quality, how might we, as public institutions, be challenged to meet the best cost while also recognizing that access must be and will be paramount? So the Ontario wait time strategy really has taken new money and, in a sense, flowed a little bit against the historical funding model of healthcare. This is a surprise to many, but unlike physician revenue, where the more you do, for example, if I do orthopedic surgery, the more knees that I do, the more bills I can send to government because it is a fee-for-service basis. And some would say it's a piecemeal work basis. 1 procedure equals X dollars, 10 procedures equals X times 10. On the other end of the spectrum, hospital budgets are primarily global budgets. Here is your $200 million, $500 million, $700 million, pick your favorite number. budget, and within that you need to provide care for your population. So in a sense, at times we've actually seen us collide a little bit between saying what we want physicians to provide is more care, and when hospitals are forced to balance their budget, it would be to provide the same level of care they have historically, and if they're still running in some degree of surplus, adding additional. The wait times money flows in a slightly different way, and it says the following. If you do more, and you can do it at the cheapest rate or amongst the cheapest rates in the province, then you will be entitled to do more, and more activity will in fact mean more revenue. So I think there's been some positives in that. The negatives would primarily be around infrastructure. So unfortunately, unlike our colleagues to the south, Ontario does not exist in an overbuilt health system. As many of you will know in the health sector who are here tonight, our hospitals operate above 85% capacity. I saw some data today where in many areas of internal medicine, we're operating above 100% capacity. In the United States, in a much larger system by way of built bed per 100,000 population, if you were operating at 60% capacity, you would actually be among the highest economic performers in the United States. So the capacity in Canada to simply turn up the volume is not perhaps as great as it need be. And the challenges we're seeing, even with wait time money out there, is we don't have adequate infrastructure. We haven't, again, overbuilt in the best sense of the word, and perhaps in the worst, so that we do actually have operating rooms available. And obviously, in addition to that, one needs to have surgeons and anesthetists and nurses and others. We don't have a glut of those professionals either. So part of the challenge, how does one address wait time with limited capital infrastructure and limited healthcare professionals? Let me push on to the next slide, if I might. Just a few more folks pushing the envelope. The planning of private diagnostic clinics in Ontario and Quebec are certainly rife, and they have popped up and down over the last 15 to 20 years, certainly more so in the last number of years. In so doing, we continue to hear from the ministry the threat of fines. I know that Minister Clement federally this week fined British Columbia, I believe it was $29,000 for an infringement. And I think quite openly suggested that $29,000 on a $5 billion health system is probably not going to send a message beyond belief. So again, what message are we sending with incentive and disincentive? I believe we're going to have to come back and talk a bit more about that. The BC model we've mentioned already, increased role, they've said, increased role, let's study it, let's understand it in the private system. But what does that actually mean? Who will define that? How might we better understand that? And of course, never to be outdone, Alberta's Premier Klein said, I have a third way. Now, his third way is going to be continually shorter, I understand, in light of his earlier departure. But his question is, and a legitimate question in my opinion, might rural hospitals, might overused physical plants look at the contracting for surgical work? Again, I'd suggest it was likely to be high volume, low acuity work that would permit the shortening of the queue, the taming of the queue, which is the latest pun of words in our industry. In Mr. Klein's view, this would allow both the public hospital and private clinics to offer access to some non-emergency procedures for a fee. In my opinion, the key to this issue is really ownership and flow-through. I'll confess to believing that there's nothing wrong in working with the private sector in any way. In my opinion, it probably should be encouraged in many initiatives, so long as ownership and governorship could be permitted in a model that protects the public system, that always protects the public interest. But if we can do procedures in a lower cost way, with better throughput, perhaps better outcomes, and use private capital to do so, I believe the time has come in Canada where we must explore that. Again, in my opinion, once again, we can never blink on the issue of universality and access. And so long as we protect those issues, and I think that there are some examples in the world where that's been done a little better than we have, and certainly much better than the United States has, we may have a very, very interesting opportunity. The challenge, of course, that we see in Alberta is somewhat related to population. So the population is primarily centered in two large urban areas. Ontario is, however, a very different province, so approximately 13 million people, many centers, quite dense population along the U.S. border. will those same models of surgical acuity, outsourcing of clinical work, will it work? And I don't think we quite know that. But Premier Charest's plan suggests that he has a solution, or at least he has a mechanism to explore a solution. The Quebec solution is certainly for the private sector's role in the health system to be done, as we mentioned earlier, through public funding. Once again, the whole issue of Canada-wide discourse on the Canada Health Act. And unquestionably, the system has evolved, we've evolved, the technologies have evolved greatly since the Act was originally written. But do those principles of the Canada Health Act still apply? Should they apply in exactly the same way? Or will we be challenging ourselves to reinterpret both the Act or perhaps rewrite it? I won't bore you maybe with some of my next slides, only because I think I'll repeat myself, but their position is a bit schizophrenic. Well, that is nothing new in healthcare. I'm happy to say that we often argue on the one hand and on the other hand. Similarly, we need to look, again, at that economic wall. When we talk about what the federal vision is, when we talk about now Prime Minister Stephen Harper's vision, he has come forward, interestingly to many, to support more a Quebec-like model than an Alberta-like model. And again, that keeps all assets within the public corporation, within the public hand, and does not, in fact, permit privatization per se of the system, but does permit private contracting. Again, Minister Clement talks about wait time guarantees that have a legal force and that patients may sue if legal limits are exceeded. And this is really quite a new concept, even in the whole work of jurisprudence of the Supreme Court. The concept of economic penalty for wait time is a new concept for Canadians. It's actually a concept that has been very much rejected through the existing Public Hospitals Act, and in my mind is an area we should be extremely careful on. I would suggest that when we look again south of the border primarily, issues of litigation in no small part drive up the GDP expense of healthcare, making Canada's 9% look quite attractive relative to the 13 and 14% now being seen south of the border. John Tory, the Ontario PC Party opposition leader, has also made a comment on this. In his view, given rising costs in healthcare, allowing more private companies to build health centers with treatment covered by provincial health insurance is the best way of easing wait lists. And again, I think Mr. Tory has suggested a model that uses private capital within a public system. I believe that is a message that's emerging across political spectrum and, in fact, with our legal colleagues. Let me quote a colleague of ours, Alan Hudson, a very talented man, high-spirited neurosurgeon by background, and a person who's done a great deal of work in the Ontario government of late on wait times. He is a surgeon by background, so he gets away with this a little more than some others. But surgeons remain the masters of their own wait list and can move any patient to the front of their own line, regardless of the number of extra hip and knee cases. And Dr. Hudson's comments, I think, in some way were to chastise the profession, to suggest that throwing up your hands and simply saying, well, there's a wait list and there's nothing that I can do about it, is in fact quite untrue. That within each clinician's operating room time, that opportunity is defined by their assessment of severity, their assessment of need, their assessment of the population under service. So I think that we are now also seeing, with the advent of internet, the advent of much better information systems around, a greatly improved knowledge base amongst all consumers, and I, for one, would applaud that. We are seeing consumers look at information and ask, well, why is my wait time this long? Why can't it be like another community? That data is now becoming more easily available. Similarly, how many procedures do you do? So one issue that I think we haven't talked perhaps openly enough about, and one model where the medical factory has proven very, very wise, is the whole issue of volume and quality. If you do, our colleagues in industry wouldn't be surprised at this, if you do something frequently, you get very good at it. So there's been some very, very good evidence that suggests grouping together cataract surgeries and frankly doing nothing but cataract surgery in a dedicated number of operating rooms with a dedicated number of staff not only is increased efficiency, but improved outcome. That in fact is all you do. You get very good at it, and your patients benefit greatly because of it. An important question is how is that around quality of work life? Is that a stimulating enough environment for all clinicians? And it may not be. But that having been said, we also still, in my opinion, have the ability to blend the mix of low acuity procedures and higher acuity procedures across diverse settings. And I think we will see that happen more and more. I won't go through the throne speech since it's so frequent, but a few comments on, again, universal accessibility and equitable public system in our recent speech. Very, very important issue. Again, a little funny, I hope, for you on Mr. Romano's views. Dr. Roy, I know he has received a couple of honorary degrees, so he may be in practice soon. And again, that the scary part of Medicare. Might we, at some point, put the best of our system, accessibility and public quality, at risk? I have to confess to you, I don't believe that anyone will allow that to happen. I think those that threaten it are forgetting the wave of consumerism. That consumers won't allow that to happen. Certainly investigators, researchers won't allow that to happen. I don't believe the public watchdog of government will allow that to happen. And while not every day am I completely fond of the media, on this case I am. I don't believe that the media would allow that to happen. The accessibility of data to consider quality in healthcare is like nothing we've ever seen before. The accessibility to the patient, be it in a private or public system, remains quite remarkable and will only increase. A little bit of background on our system, which I think most of you know about. So again, just a quick mention. Medicare came about as an accommodation between professionals, mostly physicians, and their provinces. The bargaining power of physicians, the role in hospital governance, was something that was enshrined in legislation and remains such. And, of course, the fee negotiation between the province and their medical associations is an active part of that relationship. The whole extra billing issue has been something that we've talked about for a tremendously long time. And I believe that not only the profession, but the government and the public are starting to ask questions about whether that really is the central discussion or is, in fact, the discussion one of access. Canada spent $130 billion on healthcare in 2004. And it comes as a surprise to some, hopefully not all, that about a third of that money is already spent in the private sector. The private sector includes things like ambulance care, chiropractic care, eye care, dental care, a whole number of issues that you may occasionally be surprised at when you take an ambulance or get a test done. But the model that suggests that Canada has not engaged in some component of private funding of a public system is not so. I don't think we've thought about it in that way. It certainly has not been the way and direction of inpatient care or even direct physician care. But a very significant part of our delivery system has already moved its way into the private system. Are there other approaches that we should consider? Well, I think that there are. Let's learn perhaps a little, the least, I might say, although I'm a great fan of the United States overall. I'm not a great fan of the U.S. healthcare system, primarily because of cost, coverage, and access. So this is perhaps the most strategic example of a system weighted towards private finance and market mechanisms. If you have chest pain in the I was going to say the province of Florida, I'd be shocked for that, in the state of Florida, you have a 7-time greater probability of having your chest cracked open and your heart bypassed than you do in Ontario. Sadly, that is suggested by some to be a bad thing, that Ontario should be doing more. I'm going to suggest to you the exact opposite is true. That in a system geared and built appropriately to address clinical need, clinical demand, and an evidence-based approach to practice, the Ontario system has the capacity, again, thanks to the expansion, thanks to the work of Elizabeth, for centers like St. Mary's, to truly treat patients who require cardiac bypass. The challenge in the United States, as I mentioned earlier, where physicians are paid on fee-for-service and hospitals are paid on fee-for-service, through no intentional fault of anyone, if you have a cardiac surgeon and someone with chest pain and the investigation suggests that there's some blockage, they're probably not going to jump to a medical model of management. They're surgeons. They're going to jump to a surgical model of management. Now, in saying this, I in no way, shape, or form want to be disrespectful to my surgical colleagues. The envelope drops when you have capacity. The question is, what's the outcome? And the outcome as we know it today, particularly around cardiac care, is that in investigational endeavors, increasingly angiography, is an opportunity to prevent invasive surgeries. But the whole law of supply and demand must not be underestimated. If you have a lot of surgeons and you have a free market economy, guess what? You do a lot of surgery. We need not be surprised by that, but I think we need to be mindful of that as we build, and in my opinion, not overbuild the system. But we're a long way away from worrying about overbuilding our system. Similarly, in MRI, a great deal larger number of MRIs per million population, and of course, then down to the nitty-gritty. About 25% of the population is covered by Medicare, and government regulates the private market. So 75% governed by the private sector. In 1994, the total health expenditures roughly equaled, in the United States, roughly equaled the combined total for 26 OECD nations. So this is big business. It is unquestionably growing, and it is a buyer beware business. Now, juxtaposed to this are some of the finest medical establishments in the world, some of the most remarkable academic health science centers, some of the most remarkable clinicians. The challenge, of course, is how does one fund a system that is primarily built on access when access and technologies are becoming increasingly expensive and population growth and demography are pushing forward on additional responsibilities and roles. The people who need the most care in all health systems are not the wealthiest people. They are, without question, the most disadvantaged populations. So again, focusing that overbuilt system on the wealthy ignores a very, very significant population, and frankly, again, underutilizes a remarkable resource. Let me jump to the United Kingdom, a centralized national organization, the National Health Service. It's an institution unto itself in Great Britain, exists. Hospitals are state-owned and run, and everyone who works in them, including physicians, are employees of the NHS. There are some private practices, and you may have heard referred to as Harley Street, the private street in London, where some practice occurs. But still, even though we hear about private care in Britain, it's a very, very small percentage. Family physicians in Great Britain primarily work in private practices, not unlike Ontario. The majority of their funding, not unlike Ontario, is from government, and it is increasingly in both countries based on the number of registered patients in practice. Again, that evolution away from the traditional fee-for-service mechanism and into a model that says, as a provider, I have a responsibility to look after a population of patients and their comprehensive needs. Parallel systems in the United Kingdom, Bupa, there's a private sector group called Bupa and a number of other insurers, are primarily paid for by individual patients. We are now seeing them very much a part of labor relations, very much a part of management negotiation for management positions. That I no longer am arguing perhaps as ambitiously about my compensation per se. I'm arguing ambitiously about my benefits, and I want a private parallel funding model that the employer pays for my health care. That is certainly a trend we're seeing repeatedly. A couple of others, just for example, so we're not exclusively egocentric to the Commonwealth. Again, we mustn't forget about genetics. We mustn't forget about lifestyle factors. We mustn't forget about historical consumption and historical well-being. In 2002, I apologize, my data is a little old on this one, Japan spent an average of approximately $2,000 per person on health care, compared to our own at $2,931. This has, of course, been adjusted for parity. Less spending, 7.8% of GDP, versus 9.6%, and more comprehensive coverage with a less privatized system. The good news about Japan, however, from 2002 is changing a bit. We are seeing lifestyle factors like smoking, Western diet, a whole number of other issues beginning to push up that cost, and it is estimated in the course of the next 50 years our burden of illness will be similar, primarily related again to environmental exposure, diet, and a Western approach to life. I'll just perhaps skip over this one so I can cut to a bit of the meat. Australia is my next example, and I'll again just give you a very, very quick overview. The unique feature of Australia is that it is part of the Australian culture to, in addition to Medicare, carry private insurance. And approximately 85% carry a private patient-funded model. That is not to say that all who need care will or should have private insurance. All who need care do have full access. But it has become part of the culture of Australia to expect that one will pay for something from one's purse or the private purse over a longer period of time, primarily in an insurance mechanism. Private health insurance is not only available, it's encouraged. It's, again, very much part of the negotiated process of benefits in Australia. And certainly there is a levy surcharge for high-income earners of approximately $1,000 per year per family. Interestingly, in some parts of Australia, it has become vogue to be such a family that people are in competition to pay the $1,000. I have yet to believe that that's likely to happen in Ontario, but our public policymakers are hopeful, I'm sure. Not unlike what we're talking about, there are no new ideas, but perhaps just a variation on a theme. Standard wait time limits, and again, a question as to, and if you don't meet them, what's the outlet valve? And again, public expenditure, for your information, from GDP and some OECD countries. We've already talked a bit about private care, independent health facilities, another example of the quasi-private endeavor that exists in Ontario. These are very focused scope of practice environments approved by the Ministry of Health, many often run or owned by physicians or other healthcare providers, but another example of a variation on a theme in the Ontario healthcare system, and a couple of private sector hospitals, although we don't perhaps think of them like this. The Shouldice Hospital in Toronto, a hernia factory, again in the best sense of the word, nearby here, Homewood, another private hospital. They're the exception in the Canadian and the Ontario system. The majority, as you know, are the 158 public hospitals. A couple of other examples across Canada, one in the Cambie Surgery Centre in British Columbia. This is an environment that has said, I will focus exclusively on workplace safety injuries. Workplace safety is funded from a different pool. Revenue has been seen as quite robust in that regard. So we are starting to see providers migrate to where revenue might exist and where dissatisfaction or less than optimal satisfaction does exist. The new president of the Canadian Medical Association, Dr. Brian Day, in fact, heads this clinic. And I would suggest, with his appointment, signals very strongly the overall opinion of physicians that, as the public has realized, we need to look at doing these things in a different way, while again being true to our cultural and ethical heritage. Some further examples, just to continue on the theme. The Ottawa Valley MRI Clinic is a private clinic in Hull, Quebec. The U.S. system of reimbursement. Some would say, and I think there's a fair debate in this issue, that Canada need not invest in a private sector health system, that the best outlet in the world exists just south of the 49th parallel. I have to confess to you, I see truly the one hand and the other hand of this debate. On the one hand, I think that it is true that any Canadian who wishes to purchase service is only a car ride or plane ride away from a very qualified medical center in the United States. On the other hand, we need to think about economic prosperity, investment, and mechanisms to both grow our own revenue streams and grow our own internal health system interdependence. So do we wish to advantage, do we wish to stimulate a foreign economy, or should we in fact look at mechanisms within our own economy in order to preserve the public but stimulate the private, again, remaining true to our values? So I'm sure you've picked up by now with my blathering on and droning on about private health care. It is certainly not illegal, and some have continued to believe this, but I know you will all be wise to say certainly not. Much of what we do in healthcare has been privately funded. But I think the most important but, no one in the Canadian system, regardless of whether it happens to fall within the public or private domain, who is acutely ill will be denied access. So a little bit about the provinces, just to give you a quick C to C to C. Little private care is available in Newfoundland. There's no serious discussion about further privatization. I would suggest if you look at the economic realities of Newfoundland, that the wherewithal outside of the public purse simply does not exist. Similarly, in Nova Scotia, There are no moves to further privatize healthcare per se, but there's a great deal of private delivery occurring in the long-term care system, and there are some significant co-payment issues, a contribution of a part each day for the care provided to deliverers of long-term care. Private insurance options are also available, but they are in fact performed in the public system. New Brunswick, another quick run through the Maritimes. Again, no further privatization, but not unlike the other provinces we've discussed. There are significant issues in long-term care, some diagnostic facilities, and certainly, once again, the public system will purchase from the private sector, not the other way around. PEI, certainly the Ministry of Health actually in Prince Edward Island runs the system, so it is actually government who operates the system. And there are certainly no discussions at this time of private delivery, but again, the whole high co-payment issue, increasing dollars for co-payments, even in acute care, are being considered. In Quebec, as we've discussed already, there are some types of treatment at private clinics. If Premier Charest sees this through, it will certainly challenge the Quebec delivery system to either respond or run the risk of losing the business, quote unquote, to private sector providers. I think the challenge in Quebec and most of these areas is the rate, the individual rate for an intervention, adequate to capitalize the intervention. So by that I mean, if you'd like to offer a private sector MRI, you would need to be able to obviously either buy, rent, or procure an MRI. If the rate per thousand delivery of service is inadequate for that to make economic sense, then it will in fact come back and rest on the public system. I would suggest to you that that's probably the most important lever that will see us debate where the rate limiting factors are and what the actual rate dollar will be in order to remunerate us. I've already bored you a bit about Ontario. Manitoba is somewhat the status quo, waiting and watching. Saskatchewan's less than 1 million people and very economically diverse. Non-diverse, very economically stagnant at the moment. So again, there are still some discussions about private treatment in Tommy Douglas's own patch. And of course, in Alberta, we've heard what Mr. Klein and the Third Way looks like. I'm going to move on through a couple of these others so we might get forward and talk a little bit about what might suggest how we go forward. Let me ask you to just jump forward. You're way ahead of me already. Thank you. The position of the justices, to go back to where we started. Extending wait times without recourse to alternatives violates our right to life and personal security in this majority decision with dissent. The decision didn't consider the absence of a parallel private system in Canada, and the legal effect of the judgment is in fact limited to Quebec. And as you know, case law and the judicial system in Quebec is significantly different than other provinces. There has certainly been very much in many provinces, including Quebec, a bit of a wait-and-see attitude. What will this mean? Where might this lead us? Where might we go from here? So I think that we are now at a point of seeing how would one operationalize the model that says if you don't get the service in the time required, you will in fact have the capacity to purchase it. Where will you purchase it? Who will purchase it? How will it be purchased? With what kind of economic wherewithal? What about follow-up care? There are many, many, many questions. But in my view, the challenge has been laid before us. Respond to wait times, respond to access, and do so effectively and efficiently, or we will give the opportunity to others. Some suggestions or some possibilities. I'd suggest to you that the debate is not simply about public or private delivery, but perhaps more importantly about ownership and control of the system. And so long as we see the system primarily legislated and governed through public boards with funder of public purse, I believe that the system is in good hands. Local governance can certainly entrench public control, and I know in Kitchener-Waterloo the importance of local government has been long and strong and has a bright future. But how might local governance work with a responsive and a controlled private sector? I believe the entrepreneurial nature of this community might make it one of the unique communities in the country to explore this further. The goals of the Canada Health Act and our expectation of a high quality of service can and should create some inherent tension. I would suggest to you that it will be hard without additional revenue to significantly improve on all areas of the system, which would address both access, quality, and modalities of treatment that are modern and renewable. Private health care, no question, is already a part of the solution, but healthy public debate can stimulate new discussions on challenges, and they are grave. The challenges of workforce, the challenges of supply and demand, the ever-mounting challenges of appropriate incentives as opposed to malaligned incentives. The court did not comment on the mixture or mixing of public and private care. Our legal colleagues have, however, argued that the Quebec bill, by allowing public and private interface, goes well beyond the scope of the decision. Mr. Charest has proposed the use of public funds to pay private clinics to perform, for example, cataract operations. Is that in any way, shape, or form inconsistent with the ruling of the courts? Again, open to interpretation. Let me finish with a couple of slides. One, the inherent conflict of our goals. I'll just take you back to the original act which governs much of what we do in healthcare and remind you that to qualify for money and the autonomy of the health delivery system, we must adhere to the existing principles of the Canada Health Act. And they are universality, comprehensiveness, equitable access, portability, and public administrations. Canadians, understandably, Ontarians, expect very high-quality services, and they expect the colleges, the regulatory bodies, to ensure that we have outstanding colleagues providing that in an evidence-based way. I want to close by suggesting a framework that I think may in fact underlie why we have some of the problems that we do face. This is a bit of work originally built by the British Medical Journal, the BMJ, published in 2001. And I think the postulation is a wise one. As we look at, for example, in your lower left-hand corner, you'll see the concept of equitable access. Well, unquestionably, equity is an inherent driver in Canadian values, and particularly in the delivery of the Canadian healthcare system. The theoreticians involved with the BMJ suggested that getting all three of these things without spending greatly in excess of the resources we spend today was in fact close to impossible. Getting two of them was very possible. The social debate now has to merge towards which two are the most important, or, if we desire three, how will we significantly fund a significant increase in spending? And as I know every politician can tell you, and every hospital administrator I'm sure as well, when people say, do you think that the healthcare system needs additional help, needs to be remodeled, needs to be better funded, needs to have renewal, everyone's hand goes up, absolutely everyone. When you then say, who would like to pay more taxes in order to do that? I could ask for a show of hands, and I don't think it would look a lot different than what I'm looking at now. Most Canadians are saying, I don't want to pay a higher tax rate. I actually believe that there should be within our tax base an ability to do this, or, alternately, that there should be some challenge to bring other providers, public or private sector providers, to challenge whether or not the base rate is in fact as low as we can possibly make it with equal outcomes. So I think the model holds up, and I'll perhaps close with this and leave you with it to think about whether you believe these are actually inherent conflicts in our goals. This model suggests, and I'd support, that equitable access is something that we have for the most part in Ontario. Equitable, not perfect. And almost exclusively, we do have among the highest quality of services. Our success rates, our longevity rates, our interoperative rates, very, very, very competitive internationally. What we haven't had, and still don't have, are perhaps a comprehensive range of technologies, therapies, and drugs. And you'll have heard, no doubt, the recent debate about additional very, very expensive drugs for cancer care, some new models of imaging, like things like positron emission tomography, which simply have not been introduced into the system, in part because of a belief that the evidence isn't conclusive that they're completely useful, and in part because we haven't identified a way to fund them. The United States, on the other hand, lives in a world where very, very high-quality services exist, with a very, very comprehensive range of technologies and therapies. But once again, equity is certainly lost, again, that 80 to 90 million uninsured or underinsured. The UK, taking the other end of the triangle, has provided equitable access through the National Health Service, and it's provided, more so than Ontario, a comprehensive range of technologies, therapies, drugs. They've introduced those things earlier in the clinical process than our country has been able to do so. But the issue in England is quality of service, centralization of service, volume of service, and outcome. So I'll perhaps close by suggesting that might be our most important debate. Not if private health care can coexist with public health care. It can and it does. But how might we address the remaining inherent goals and conflicts? And how might we challenge that in a model where best cost and best quality are de rigueur? In closing, I want to thank the folks here at St. Jerome's. Again, pay tribute to Mr. Sweeney, who was obviously quite a remarkable man. And thank you very much for your attention.
Any questions? I just thought of a solution during your talk.
Oh, good.
Actually, that we could perhaps allow professors to perform surgery. I mean, they are doctors after all. And, I mean, the patient outcome might not be the best, but the cost would be effective. Dr. Smith could still perform surgery since he's both a medical doctor and has a DPhil from the UK. So he's Dr. Smith.
Well, I wouldn't really agree with that.
That's because you're a doctor. We have some time for questions. If someone wants to ask a question, please raise your hand. I will bring the microphone to you, and we would welcome your participation. Can you move this way just a little?
Hello. Thank you very much for a very interesting perspective. I've worked in healthcare for 35 years, and in the last 3 years, I've worked in accumulating information on public policy in order to educate and inform the general public. I have 2 questions about conflict following your delivery. The first one is about the local scene. You said that you're operating at 85% capacity.
The system is deemed to be operating efficiently at 85%. Unfortunately, we're operating some days beyond 100% capacity.
Okay, and that was where I was having some conflict, because even for nurses at the bedside, they're working patient care hours ideally are 80 to 100% on the grasp, and nurses are working anywhere up from 100 to 140 patient care hours, and 40% of them are going to be retired in the next few years. So even if you were operating at 85%, you're not going to have enough frontline people to do the work. So I think the real issue here is not developing technologies for discoveries and having competition between drug companies for the best and most expensive drug, but to get those frontliners there to actually do the care, because stress increases disease as well. And we have stress amongst our frontliners as well as our patients, simply due to the fact that we're operating on a thin string now. My other question around conflict, and this is a big one. We've had a 3-tier system in Canada for years. It is the publicly funded tier that is now being threatened to be split. And this is the one tier that many people are really concerned about, not just because of wait times or expenses or even gaining all five of those principles within the care structure. If any of our system is privatized and somebody is operating a privately run health Care Center. Under NAFTA, any foreign agent can come into Canada and challenge that. That is a very dangerous precedent. And it would be, I would really recommend that everybody in this room learn what that means, because it doesn't mean is it NAFTA or is it health care, but it might mean that we should be asking our MPPs and our MPs to push health care off the table at the NAFTA. And instead, our government is squeaking in little bits all the time. So that is a huge conflict, and I do not think that the general public is aware of that.
Let me try to respond to both. I think I'd respectfully disagree that the public has made the decision that we should simply concentrate on addressing existing supply and demand issues divorced from new technologies. That consistently, I believe Ontarians have consistently pushed forward and said, I don't only want adequate access, and timely access, but I want access to the best quality of care, and that does include the best technology. The model that I completely agree with your view that we must address the issue of renewal. And to that end, I know Waterloo is a community where distributive medical education has just arrived, so I'm quite encouraged to see new medical school, nursing placements, etc. I think the other issue we have to explore, however, is scope of practice. And to suggest that a nurse is a nurse is a nurse, as we've always done, sadly, through labor negotiations, is probably incorrect. I don't, as you've heard from my talk, think that there's a lot of things I'd want to borrow de novo from the United States. But I think we do have to explore whether or not an anesthetist has to be present for every procedure, or can a nurse anesthetist do that work. There's very, very good evidence that with the appropriate structure of low acuity, low risk diseases, not all of the system needs to be physician-driven. My view is, and I think I've heard this from many, many of my clinical colleagues, that we are so tired. You've already mentioned the burnout. People are so tired. The old issue of turf has been bypassed by we simply need to find some people to do the work. I believe one of the inherent conflicts is super specialization and in these hallowed halls, intellectual rigor. So, for example, we've taken nursing from a 2-year program to a 4-year baccalaureate program. Probably that's a very good thing. I know that is a very good thing intellectually. But it will certainly leave us an additional 2-year window where we'll decrease the number of grads. I think we have to ask the question, will a 4-year graduate nurse want to do bedside, patient-side, community-side nursing all of her or his career? And the answer to that is probably not. So I think we will be looking at a different kind of professional. I think we will be challenging professionals to look at a different scope of practice. And I think, in fact, we won't escape the view that it's not good enough to just get adequate access for the existing technologies. Ontarians want cutting-edge technologies. The NAFTA issue, I'll confess, you're probably much more informed on the fine print of NAFTA than I am. I guess the free market economists would say, if we're so overworked and we're so under in supply, would it be a bad thing if alternate providers came north of the border and if they brought with them other healthcare delivery agents? That's a question that communities, governments will have to answer. The ethical debate often ranges on why would one pirate raid, whatever the right term, other countries, many of them who are of lower socioeconomic status, in order to attract doctors and nurses to Canada. So we have many doctors and nurses who've come from South Africa, who've come from other Commonwealth countries, but who've also come from a significant number of very disadvantaged countries. So I think you face an ethical debate on immigration, around who's coming, how are you attracting them here, and what does that mean in their own home country? Surely to God, attracting more South African physicians and nurses, while it may be great for Ontario, is not great for South Africa. So I think we're in, these are issues of moral debate, of ethical debate, how appropriate we're at St. Jerome's, how appropriate we're recognizing Mr. Sweeney, who challenged that and who pushed that forward. But I don't think we can avoid the debate. And I don't think we can avoid the reality that the same system, in the same way, will be here 10 years from now. It won't be. From your comments, I think we'd agree. We're probably going to agree to disagree a little bit about some of the market forces and some of the risks. But at the end of the day, it's about patient care, and we have to deliver on that. And the most important ingredient in patient satisfaction is staff satisfaction. If we have disgruntled employees, physicians, nurses, OTs, PTs, we won't have happy patients. No, I'm sorry. There was just a lady waving over there, so I was just suggesting to David she might be next.
One thing that I haven't heard mentioned all night is preventative care.
Yes.
You talked about alternative practitioners coming from other countries, but you still stayed within the allopathic model. And my strong belief is that we are personally responsible for our health. I mean, I know there are genetic factors, and I know that there are things that happen to us that we can't always prevent. But I don't see enough education, enough emphasis on preventing a lot of the problems. What I see is an escalating system that is looking for more funding when I think we probably need to go a step lower and do more educating and let people prevent some of the problems. I guess one of the things that I've heard of, and maybe it's unreasonable, but I've heard that there are countries where the doctors get paid if the patients stay healthy. Mm-hmm. If the patient's not healthy, the doctor does not get paid.
Mm-hmm. It's an interesting model. There are some, and you've identified a very great weakness in my talk tonight. I confess to you, my day-to-day working life is in the acute care hospital, and I've strayed too much into my own patch. I apologize for that. I think part of the problem is often we look to the wrong people to do preventive care. Hospitals are great places to look after illness, but I'd reject the view that we're great places to look after health in the broadest model that you're describing. So I believe the marriage of the public health departments, of educators within the school system, of perhaps a new model of patient advocate, couldn't agree with you more that prevention is a big issue. The challenge, in my opinion, is that one has a very long-term payoff, that starting with prevention, and Ms. Whitmer could correct me if I'm wrong, while it's remarkably important, it's very difficult when you have medical staff, hospitals, and others who are at your door with wait lists, with shortages, with cancer care waiting. And if you have a limited pot, there's a limited pie in the public model of taxation, which do you pick? And sadly, perhaps, or either by ethical debate, we end up picking the immediate illness need as opposed to the long-term prevention need. And to do so, frankly, preventive issues before they have really significant economic impact, probably a 20-year time frame. So in fact, we need to think about how would one additionally fund the system until we started to reap those very great benefits 20 years out. Again, in the model of a fixed pie of expenditure, it's a very, very difficult challenge. One of my colleagues, I think, has got some very good ideas on this, and that is that perhaps that's the private sector system in healthcare. That's the personal responsibility component of healthcare. And frankly, I can certainly see how that might be a model. The challenge is, particularly also when we look at patient populations, what does one do with the smoker, the eater, the whatever? And from my personal view, when the patient is at the door, we're not going to ration care based on poor choice in lifestyle. I don't think that's the ethical approach to treatment we want in Ontario. So I completely agree with you. I think you're absolutely on the right track. It's hard getting people caught up with that issue, and it's hard trying to fund both without significant increases, either through public pay or private pay.
Okay.
I have a question about the private fund hospital. And since I'm late for this lecture, I don't know whether you have covered it or not. My question is, why the private funded hospital in Canada is illegal, and what's the government concern on private funded hospital? Thank you.
It's not completely illegal. We have a few examples. The majority are publicly funded, and I don't know that it's the government fear. I think that it's the general public fear of will privately funded health care advantage those who are in fact economically advantaged and punish those who aren't. And we know from very good Canadian data, we should be proud of Canada's research role in the world, particularly on population health, that it is those folks who are who are the most disadvantaged socioeconomically who have the greatest burden of illness. So the worry is, will we migrate into a system where the wealthy have actually too much care because they can shop for it, and the poor have woefully too little care? I think the challenge is somehow suggesting that we will not allow that to happen, and I believe that we may have strong enough data systems, better evidence in order to begin looking at that and not be frightened of involving the private sector, in my opinion, so long as governance and ownership doesn't reside there.
Okay, we have a question here.
Excuse me, Jack Rooney here, and Dr. Smith. The first thing that popped into my head when I saw your double hat-wearing capability was, is this gentleman drawing salaries from both hospitals? Are you a double dipper?
You know what? Hospital CEOs and their salaries are not easy to defend on the podium. That having been said, no, I'm not. I actually am remunerated once for the job that I do. Both St. Mary's and St. Joseph's corporations contribute to my overpaid status, I'm told by my colleagues.
Thanks very much. But yes, I know in the region we've had a couple of occasions where CEO salaries have come into question. The other was a comment, and basically, again, it comes from personal experience. I was just holidaying in the southern U.S., and in Las Vegas, they have a critical shortage of OB-GYN physicians, and the reason they've been driven out is insurance costs. And notice Mr. Clement's comments on your slide where he would think that opening our healthcare system to more jurisprudence would be a good way to go. And man, that is scary.
Yeah, I interpreted the minister's comments a little differently. I think what he was hopefully suggesting is that's where it could lead. So I, like you, would say the loser out of a system that becomes principally involved in legal suit and economic settlement is ultimately the patient and the funder. One of the very great things about the Public Hospitals Act is that it, for the very great part, limits compensation, as does case law in Ontario, to very modest amounts by comparison to the many, many $1 million in the United States. The OB-GYN issue that you've described is such that an OB-GYN in areas of high litigation would actually have to pay more money for their insurance to practice than they would be able to bill. Now that obviously becomes a challenge for a woman who's about to have a baby. And while I think we have some very good examples of controlling costs, like midwives and family physicians as in a very, very important role in shared care, at some point there is a population of people who unquestionably need specialty care and obstetrics. So I, like you, would share the view. I think Minister Clement's comments, as I interpret them, are to suggest that we don't want to end up there. And in order to prevent us from ending up there, we need to find a model that allows us to preserve access and equity and not result in a system of litigation and debate, inenviable debate.
Okay.
Earlier in your presentation, you mentioned that the government system wouldn't go ahead and determine the wait time, that it wasn't their strength. It would be the medical system. And then you also mentioned that if you went to a public health service, you wouldn't turn anybody away. When it comes to a private system, who determines whether or not you're wealthy enough to afford their service? Is it like a mortgage approval or so, that there's a a person or an individual that sits and assesses your value, your wealth, or so forth before you receive that kind of care?
In the Canadian system, I believe the examples are such that so far, with very few exceptions, the private deliverer is contracted by the public system, be that directly through a regional health authority or in some cases through a hospital. So to the patient, that would be completely invisible. So in Alberta, as an example, the Alberta Regional Purchasing Authority would purchase X thousand cataracts. The hospital and physicians involved in cataract care would refer them to this group. This group would do the work. They'd capitalize it and again create that focused factory, resulting in driving down the unit cost. So in that case, to patients, it would be as invisible as it is today. In the United States, and in the model of true market-driven health care, one pays as one enters the hospital. So in many, if you go to the Mayo Clinic, which is a marvelous medical establishment, you're treated very well, but before we treat you, you go line up with your credit card or your bank draft. And culturally, that's something that, or of course, your insurance coverage, that there, of course, are many, many Americans who, for the most part, are covered by insurance providers. But that model is a true free market economy of medical care. I don't believe that's where we're going in Ontario. And frankly, I don't believe that would be for the best interests of we or the private sector.
Mike Chow, spiritual care at St. Mary's and St. Joe's at Hamilton. I know this is a bit beyond the scope of the topic, Dr. Smith, but I wonder, in terms of the whole system of health delivery, if we were to go beyond just the delivery of services within the hospital system and take into account the community and some of the services that are delivered there, I wonder if there's any opportunities for maybe promoting the health model and the prevention model, and whether you have a comment or some experience about that.
Yeah, a little bit to your colleague, a couple of seats down's point as well. Again, I think that it's an incredibly important concept, and I think that we are now very advanced in academic institutions in better understanding promotion, prevention, uptake, social marketing. I'm told that the marketing companies of Ontario can tell you who are the most likely people to have, pick your favorite, gallbladder disease, and what newspapers or magazines do they most read, and what radio stations do they most listen to. And that's a tremendously powerful social marketing opportunity to begin to say, well, let's target groups at highest risk. So I think that's a good start. I'll confess, I don't think those of us, as I mentioned earlier, I'm not a clinician. I'm an academician by background and an administrator by reality. So the real people who practice should perhaps say this more than I. But I don't believe that it's people who work in hospitals who have the best skill set to educate people about prevention. Frankly, if you look at our lifestyle in hospitals, we'd be the antithesis of good health. So I actually think that we should I think this is a remarkable opportunity for public health nursing. I think it's a remarkable opportunity for professional health educators. Dr. Mintzberg at McGill has suggested that this is a remarkable opportunity for patient advocates to again really look and say, what services are out there? There have been many who in the model of prevention have suggested a savings account, that if we're going to introduce increasingly market-driven forces, that if you exercise well and if you don't eat fatty foods and if you don't live like I live, you should be advantaged. And you know what? There might even be an economic advantage either through taxation or others. So I think we're at an interesting time to bring together public health educators and perhaps policymakers to think about, might we consider some differential tax ratio? My political friends can tell me here that it might be impossible, and I could appreciate that it would be, to administer relative to the cost, but might we consider some free market mechanisms of incenting better health behaviors? But to be very honest with you, I think we're the wrong group to do it. We are focused on illness care, and we want to be more focused on health care, but frankly, our core business in hospitals is to look after sick people. And I think we do that pretty well. We don't do prevention well.
Thank you for your talk. Pardon me if this is a naive student question. I was just wondering if if one of the pressing problems stem from the fact that there is a shortage of qualified medical practitioners, which wasn't mentioned explicitly in your talk, but you mentioned something about doctors get better if they perform something more often. Thank you.
Unquestionably, we are short, and as our colleague back in the audience earlier mentioned, we'll be shorter. That we have a massive retirement bulge happening. We have growing the inverse pyramid of an aging population. So unquestionably, that's a challenge. Again, the good news, we've radically increased the number. We're trying to radically increase the number of medical students, of nursing placements. We are exploring alternate mechanisms of delivery, changing of scope of practice. We are looking at technologies, and I actually think that there may be a remarkable salvation in technology. So, and I'm not suggesting that we're there or should be there today, but I was listening to the CBC the other day, and they were talking about a very successful public hospital in Southern California. And they were quite challenged by a shortage of radiologists. They didn't have enough radiologists. And the result was that they had a very, very hard time covering the hospital at night if they had to read an advanced radiologic scan, an MRI, a volume CT, a PET scan, what have you. So the model that they used, it was a new hospital and had a great deal of IT, a great deal of information technology centered at it. They contracted with some physicians in Australia. And it's 12 hours later or 14 hours later, I can't remember the time difference, but whatever number of hours later, it's late enough that, guess what, when I need that x-ray at 3 in the morning, they're already at work, and it's simply another bit of incremental revenue. Similarly, I think in surgery, we're having some of those same challenges. Pathology is an area we just are not training enough people, and we can't attract them in at the current rate. So frozen sections, which really means taking out that bit of organ that might sadly have a cancer cell in it and freezing it and slicing it up and then looking at it with the pathologist, again, with the IT infrastructure, with the digital world we're living in, offers us some solutions, offers us some opportunities. I think, though, when I say that, the challenge is never to forget, and I'm really apologize, I should have stressed this much earlier in my talk. The solution about public and private, about balanced or imbalanced, about technology, is all very interesting, but it pales by comparison to the importance of the exquisite relationship between providers and patients and families. And if we forget about, no matter how sophisticated we become, the dignity of the patient, the respect for human life, the approach to practice that reminds us that, as in our case with the St. Joe's system, that there's an honor in service, that there's an honor in the delivery of care to those who are ill and needy. That has to be at the center, regardless of how we structure the system. But beyond that, I actually think we're on a precipice of technology that'll be remarkable, so long as we don't let technology drive our passion and compassion out of clinical care.
I have a question. Is that okay now? I just have a question with regard to the lens. Would you make any comment regarding the effectiveness or the impact of lens on healthcare or on hospital payment, et cetera?
Am I allowed to say no comment, or will I have to answer this one? The health critic is here, so she could probably do this better than I. I'm going to try to tread
pretty
carefully.
Open-ended. So.
It is. You're safe. I guess here's my view. I believe that it's very difficult to argue against the concept of local health integrated networks. But I think one has to go back and talk about, well, what does that mean? What will success look like? How does one measure that? What goals are we trying to achieve? So I think if the LHINs evolve in a model that really tries to embrace macro planning, how many doctors do we need? If we don't have enough doctors, what kind of other professionals could we recruit? How might we look at the delivery of services across geographically disparate areas? If they stay at a component level of planning and thinking about creative solutions and work closely with providers, I think that LHINs can be quite successful. I have not seen any structure that successfully moves money around in what is still essentially a pie-sharing exercise. That there really is only so much money that we have now or are likely to have in the system. So if the LHIN's role is to, under the discussion of planning, actually look at fiscal reduction or fiscal control, I think that they have a challenge ahead. Because I think, I'm not suggesting we should plan in isolation of economic reality, but I think we should plan in a model that says, well, how might we do this with the inputs that are available? I think the last issue is the challenge, if there is one, is ensuring that ordering council appointments by any government to people of that view, doesn't constrain their voice to the mandate or metric of the government of the day. But from what I've seen in our LIN here in Kitchener-Waterloo and in the other LIN that I work in, we've selected very, very fine people. The chairs, the CEOs are good people who know the system. So I'm buoyed by that, but I guess the bottom line is it's a bit early to tell. The down issue, if there is one, and I want to actually finish on an up rather than a down, is we look across this country. If you look at the newspapers in Vancouver today, sadly I heard the emergency docs in the Vancouver General Hospital today were giving unsigned letters to their patients telling them that they felt the environment was no longer safe and that they shouldn't be treated here because they didn't feel the structure was adequate or the infrastructure was appropriate. So that's a model that's gone to regional governments. And again, if you look across the country, I don't think you hear a different song. We don't have enough doctors. We don't have enough nurses. We'd like to have more technology, and we need it. We have an aging infrastructure. So on the one hand, I don't think the structure of the system will define that. I think it'll be the processes and the people within it. But let me finish by maybe apologizing for a bit of a sin that I've committed tonight. And that is I've talked far too much about the negatives of our healthcare system. And I'm mindful of the view that I can think of no other industry where we spend almost all of our time telling each other how bad it is when, in fact, by international standards, it's still quite a remarkable system. It is by no way, shape, or form perfect, but there is no perfect health system in the world. We have mastered the view of access. There is excellent access. We are mastering the view of equity. We have unbelievable opportunity. And I think the risk of our branding colleagues, I've heard some of our politicians talk about this, and I applaud them for it, is that if we keep telling ourselves that it's all bad, let's not be surprised when morale is low, when people think, well, I don't know that I'd want to come and work here. All I hear you talking about is how horrible it is. Look at this community, a new cancer center, a new cardiac center, new physical plants being constructed, unbelievably successful fundraising initiatives, an economic base that's supporting health development. There are so many things to be pleased about, and even though I broke the rule tonight by talking probably too much about what we should fix, we have it 80% right. I hope we'll put the rest of our energy into getting the other 20% better than it is, but we are well on our way with a great system. Maybe I'll stop with that.
Thank you so much for that. And as usual at the St. Jerome Centre, I will ask Dr. Michael Higgins to thank our speaker this evening.
David started off with a Lenten reflection that was disconcerting in the extreme. And Kevin concludes reflecting on sin. So it seems altogether perfect to put this within the context of a Catholic institution. David had mentioned earlier about starting off by cracking a joke about 3 Irish brothers. Now, I don't know why they would have to be Irish. And not that I'm a chauvinist. I'm not actually Hibernian. I was born in Toronto. I'm a native Torontonian. My parents are Torontonians. But their parents were English. But the name Higgins seems to identify me as Irish ineradicably. But I thought, suppose I got up, dealing with a name like Saljak, and cracked a joke about 3 Slovenian brothers in the pubs of Ljubljana. Okay? Where would that get me? But it's not about pubs that we were talking about tonight, of course, but about a Roman Catholic ministry in healthcare. Not a ministry to Roman Catholics, ministry to the world. But a ministry that comes in no small part out of the Christian churches and the Roman Catholic Church in particular. The honor in service that Kevin referred to at the end struck me about this cardinal importance of dignity and respect for life that are features of a comprehensive and meaningful and granted healthcare Catholic service. Why have it in the center? Well, the Centre provides an excellent opportunity in many ways for ongoing education. That's why the St. Jerome Centre for Catholic Experience exists, why Father Norm Choate many years ago set about to establish it, and why it flourishes with literally now, not hundreds in a year, but thousands in a year, coming and participating right across the spectrum, socioeconomic, religious, ethnic, to learn about issues. Tonight's lecture, the John Sweeney lecture on healthcare issues, is particularly important in the context of the matters that were raised by Kevin Smith tonight. An informed public is, in fact, a healthy public. And that's what education is about, keeping people informed about issues, allowing them to be debated in a public forum. And one of the reasons why the question and answer period is often amongst the most dynamic components in the evening. Learning about the difference between preventative versus acute care, and understanding that there's a more comprehensive meaning to health than sometimes we realize when we focus only on illness. I was reminded of some of these in the context of recent discussions of which I have been part, or at least I've been listening and participating that way, at AUCC meetings in Ottawa, in talking about internationalization with several deputy ministers, and how the universities, and no small part through their internationalization initiatives, often contribute in a negative way to depleting the sources. And so what happens is, in research and in healthcare, large numbers of people come, study, and remain. And so many countries in Africa, South Africa is one of them, but certainly Ethiopia and many of the others, even more markedly so, are faced with a depletion of their resources in countries and jurisdictions that most desperately need them. One has to ask the question at the political level, at the university level, and indeed at the healthcare level, what is the ethics in this? Kevin has provided us tonight with an excellent summary of the events as they have unfolded over this Supreme Court decision, the various themes involved, the major players, the conflicts engaged, the rhetorical posturing that inevitably you find, the legal ramifications, and indeed the political fallout. What are the ethical, spiritual, and social consequences of the privatization, or indeed the partial privatization, of our healthcare system in this country? Caricaturing, polarizing, and reducing fairly complex arguments to simple-minded sound bites accomplishes very little in the end, but to confounding the debate. All the more reason, then, for this kind of Sweeney lecture on current issues in healthcare. Many of the issues that Kevin alighted on tonight reminded me of some of the important social issues going on in our society at large. For instance, the growth in health awareness. Those of you who are media junkies will know that André Picard of the Globe and Mail is but one of many healthcare specialists that our major media outlets now employ on a regular basis to provide informed commentary, whether it's in public broadcasting or whether it's through the newspaper outlets. The New Yorker and the New York Times have provided some of the most powerful investigative and highly critical analyses of the American system. And the recent debate over the Canadian Medical Association Journal is a reminder of how much value we attach to free and uninterrupted investigation. The ongoing aftershocks of the Apothec versus Nancy Olivieri crisis at the Sick Children's Hospital in Toronto is a reminder that health care matters to all of us, not in terms just only of clinical delivery, but in terms of independence, research, and all the issues that matter to the free-functioning society. Improved or enhanced familiarity with health care issues, then, with medical politics and with competing social priorities, is extremely important. And the Sweeney Lecture and the Centre, by providing the occasion for this, underscore the importance of this in the context of ongoing education. St. John and St. Elizabeth Hospital in London, England, is currently involved in a quite critical re-examination of its own mission. There's a debate among all the parties and supporters of this unique healthcare operation in London as it wars over its mandate. providing special gynecological and cosmetic care as opposed to the needs of the disadvantaged. In other words, the original mission or foundation of this unique hospital supported by the Knights of Malta. So there are many issues that come to mind as we listen to this, not only in the current context or even in the local context, but in the broader. And so I particularly appreciated Kevin's succinct comparative review, his juxtaposing the Canadian jurisdiction with the US, with the UK, with Australia, and with Japan, but then also looking among the Canadian jurisdictions by doing a pan-provincial review. He reminded us again and again of the critical principles and values, 5 principles in fact, but specifically underscoring universality and accessibility of the Canada Health Act and how we need to constantly interpret and ensure them. This underscored for me, in a way, the balancing act of a successful healthcare CEO, dealing with politicians, dealing with the patients, dealing with the healthcare professionals, and indeed dealing with the entrepreneurs. All of that requires, in a way, going back to first sources, the inherent goals of the primary vision of the institution. St. Joseph's Healthcare System and St. Mary's General Hospital are very kind in providing the support for this kind of lecture. But they're more than kind. It exercises a certain kind of vision and sensitivity to the ongoing and unfolding social implications of informed healthcare discussion. The St. Jerome Centre for Catholic Experience is proud to be able to provide the locus for this, and particularly the title. John Sweeney was our first lay chancellor, and he was a man who was dedicated to precisely the unfolding and continuing education of the public in all areas of appropriate interface, one of them being not only education and healthcare, but how that works within the larger context of the Catholic ministry of service to the larger community. I would also like to say, just before I conclude, that David Saljak, who has been the director of the Centre for many years here, has been recently appointed chair of the Department of Religious Studies at the University of Waterloo, and will be leaving as director of the center. He'll be going into therapy to help him cope with his lifelong ambition to actually be a stand-up comic. So therapy will be extreme. We'll miss David, his presence, his energy, his vision, his willingness to take the center to the next level, open it up to many of the most arresting issues, and his hounding various people to make sure that they come has resulted in quite a remarkable cascade of new personalities and new people coming to sit in this room and be part of the larger educational experience. His duties will be now taken up by Megan Shore, who is currently finishing her doctorate at a British university where Kevin went, not the same university, but the same jurisdiction, and we welcome her here. So thank you, Kevin, and thank you, David.
Well, let me begin by thanking Dr. Michael Higgins for delivering the 2005-2006 John Sweeney Thank You in Current Issues in Healthcare, a new funded lecture here at the St. Jerome Centre. You know, we always have CDs and tapes of our lectures available for sale at cost. This year we're offering a special deal, a collection of Dr. Higgins's thank yous of the St. Jerome Centre. This handsome 36 CD set is available at cost. Just see Carol Person at the front door. As Michael Higgins mentioned, this will be my last St. Jerome Centre event. I'm not leaving St. Jerome's University. I'll still be employed here as an associate professor of religious studies. I will be working at the University of Waterloo, and I will be double dipping. And I look forward to being paid except I'll be paid very meagerly by the University of Waterloo, just as chair, but at St. Jerome's I'll be paid meagerly as well, just because we're cheap. And I want to take this occasion just to thank a couple of people The first is Michael Higgins, who was the first director of the St. Jerome's Centre when it opened in 1982. His support for the Centre over the 7 years that I've been director has been absolutely unwavering. He has attempted at every possible opportunity to be at the Centre events, to participate in them, to take any abuse that I heap upon him with relative serenity. And hence, I think this is all part of the Michael Higgins for Saint cause that we are bringing to Rome. But he has been terrific, a terrific supporter of the Centre. And I've always felt that I've had the whole of St. Jerome's University behind me in all of these adventures at the Centre. And so whatever I've gone for, I've always felt that Michael has been there with me and for me. So thank you, Michael. I do also want to thank Doug Letson. I was actually named director of the Centre by Doug Letson. I was only in my second year at St. Jerome's, and Doug took a bit of a gamble and asked me to take this position on. And again, it was that wonderful combination of desperation and lack of judgment that led him to make this mistake, and I thank him for those defects of character. Finally, I just want to do I won't go through my usual spiel, which is to tell you that there's fair trade coffee for sale there, that there are CDs and tapes of all of our lectures available there, that there's an email list that you should sign up because if you want to get the next program's schedule as early as possible. But I do want to take a moment to thank Charisse Chinfat, who has volunteered over the weeks, over the last semester, over the last year, I should say, to help out at the Centre. And so thank you very much, Charisse. But I would also like Carol Person and her husband, Ivan, to come forward and to receive our thanks. Carol came to the Centre the same year that I did, and we have worked as a partnership wherein she does all the work and I take most of the credit. And so I think on this last occasion I would like to share with Carol our great appreciation. And her husband, Ivan, who has worked at the Centre on a volunteer basis, not even single dipping, and has really become, for me, not only a great colleague and co-worker with Carol, but a great friend. And so, Carol, please come forward and let us say thank you. And with that, I want to thank all of you for your support of the Centre over the years and for this event tonight, which has been just wonderful. Thank you, good night, and safe travel home.